Hi, I'm Dr. Paul Paddle, ear, nose and throat surgeon at the Melbourne ENT Group. In this video, I'm going to talk to you about intratympanic steroid injections for various inner ear conditions. I'll go through some of the risks and benefits, the kind of conditions that are treated, and what you might feel during one of these procedures here at the Melbourne ENT Group. This video is for patients, families and carers of patients with inner ear disorders who may benefit from the use of corticosteroid therapy for inner ear disorders. These disorders include sudden sensorineural hearing loss, endolymphatic eye drops including cochlear eye drops and autoimmune ear disorders, and Meniere's disease. Corticosteroids are drugs that work like cortisol, a natural steroid hormone in your body. These medicines reduce inflammation and alter the immune system. They can be taken as tablets or injected into the bloodstream or body tissues. Common examples of corticosteroids include prednisolone, dexamethasone, triamcinolone, and others. Corticosteroid therapy is a well-known therapeutic option for patients with acute inner ear disorders affecting the cochlea and/or vestibular balance function, causing hearing loss, tinnitus, vertigo, and/or an unbalance and oral fullness. For new patients with sensorineural hearing loss, whether new in onset or a sudden deterioration of pre-existing sensorineural hearing loss, an audiogram should be performed prior to any corticosteroid therapy. After sudden sensorineural hearing loss, there's a spontaneous improvement without any intervention in up to 30% of cases. Medical treatment with corticosteroid therapy can double the possibility of recovery, that is up to 60%. Patients with a poorer prognosis are those who suffer severe or profound sensorineural hearing loss and those who are over 60 years of age. Corticosteroid therapy is most beneficial the sooner it is started after symptoms onset. For sudden sensorineural hearing loss, corticosteroid therapy should ideally start within 72 hours of deafness onset and can be offered within 2 weeks of symptom onset as a primary treatment. Salvage treatment, which is given to patients who do not receive or do not respond to primary treatment, is typically delivered 2 to 6 weeks after the onset of symptoms. Often it is given in 2 or 3 doses that are 1 to 2 weeks apart. The initial administration route is often systemic, that is orally or via the mouth, with topical therapy or transtympanic steroids used as a salvage. With respect to systemic use, prednisolone is used, or dexamethasone, and this should be used for at least 7 to 14 days, with a tapering of the dose over a similar time period, provided there are no contraindications for its use. The medication should be used in the morning after breakfast. Administration of transtympanic steroid therapy is recommended in the following cases. 1. Failure with systemic corticotherapy, that is tablets. The presence of contraindications for systemic use of corticotherapy, such as poorly controlled diabetes, a previous good response to injections and repeat need for its use, and hearing loss duration for more than 2 weeks. First, your specialist surgeon at MEG will apply a local anaesthetic into your ear canal, either a cream, a spray, or an injection, such as Emla or lignocaine, or a lignocaine spray or mix. Next, dexamethasone with a 24 mg per ml solution will be injected through the tympanic membrane or eardrum or through a grommet into the middle ear, applying about half a ml of injection per procedure. Immediately after the injection, your surgeon will get you to lie on your side for at least 30 minutes to assist with the maximal possible absorption into the inner ear. Many patients will feel dizzy straight after the injection. This will normally settle in minutes to hours, and certainly within the first 24 hours. It is normal to hear liquid moving in the ear or feel it is dripping into the nose. This may make sounds more muffled for the first couple of days. Avoid blowing your nose for the rest of the day. Also avoid driving or the use of heavy machinery or lifting heavy objects. Use Panadol or ibuprofen for pain relief if required at home. Within the first 72 hours, keep the injected ear dry by using a waterproof earplug for at least 3 days following the injection, or for the time period advised by your specialist surgeon. You should expect a minor discharge and bleeding from the treated ear, and this may be for a short period of time. Any improvements in your symptoms for which you were treated won't be immediately obvious and may take hours to days or sometimes even weeks to be noticed. Further weekly injections, usually 2, can be arranged with your specialist surgeon if ear symptom improvement is noticed after 7 days of the first injection. This will usually be confirmed on a hearing test. You'll have further discussion of the risks and benefits with your surgeon before having any additional procedures. 1. With systemic use, there's the risk of insomnia, aggravation of pre-existing mood disorders, glaucoma, reflux and ulcers, and elevation of blood sugar and cholesterol levels. there's a very small chance of avascular femoral head necrosis, which is a specific type of acute joint condition of the hip or shoulder. With transtympanic injections, there may be ear pain, a residual perforation in the eardrum, cholesteatoma formation, which is the skin of the eardrum growing inwards into the middle ear, and scarring of the eardrum. Please note that we can't guarantee either the effectiveness or the duration of corticosteroid therapy in any case, and your specialist surgeon will discuss with you further rehabilitation options in cases of failure of medical therapy. These may include hearing rehabilitation options, including conventional hearing aids, hearing implants, and vestibular physiotherapy. If you have any further questions or concerns, please don't hesitate to contact our rooms via phone, email, visit our website, or reach out to us in live chat. Thanks for watching.